James. We're going to talk some more about Chapter 15, Pregnancy at Risk with a Gestational Onset. Some of this is going to be a little redundant for you, which is okay because some of these things are a little more complex to understand. But we get into a deeper understanding of bleeding problems that may happen and other issues that may happen that could cause complications later on. Abortion, we're talking here about spontaneous abortion, what some of you may term as miscarriage. This is usually the major cause of bleeding. It usually occurs in the second and third trimester. But remember the age of viability, 20 weeks. Pregnancy termination prior to 20 weeks gestation or with a fetus that weighs less than 500 grams are the criteria for terming it a spontaneous abortion. After that, we have other terms we'll talk about later. It will occur naturally, and as I said, lay people term it as miscarriage for spontaneous abortion because of the obvious connotations that sometimes using the term abortion takes. Pregnancy termination prior to 20 weeks or with a fetus weighing less than 500. It can be called induced, which occurs as a result of artificial or mechanical interruption. That's another form of abortion, or you may want to term it as elective abortion. These are the types of spontaneous abortion should be in your book. A threatened where the cervix is not dilated, the placenta is still attached to the uterine wall, but she does have some bleeding, and that's called a threatened AB or threatened abortion. An imminent abortion, which is where the placenta has separated from the uterine wall and the cervix is dilated and she has more bleeding. And that means that it's imminent that she is going to abort this fetus. Incomplete abortion is whenever there's a spontaneous abortion, but not all of the products of conception have passed. The embryo has passed out of the uterus, but the placenta remains, and the physician will usually have to go in and clear all of that out so that mother won't get infections and other problems. Other common causes of bleeding during the first half, we talked about this a little bit in the beginning of the semester. She may have an ectopic pregnancy and start having a lot of pain with bleeding, or gestational trophoblastic disease, which is also called the molar pregnancy. During the second half of pregnancy, she may have a placenta previa, and this is where the placenta has adhered closer to the cervix, and she'll have pain less bleeding with no pain, or abruptio placenta, where the placenta has actually started tearing from the uterine wall, and this will be painful bleeding and very painful. So, with bleeding disorders, we know we're going to have to monitor the blood pressure and pulse frequently. And one question I would ask you is hypotension an early or late sign of a bleeding disorder? We need to observe for signs and symptoms of shock. Count and weigh the pads to assess how much bleeding and save any tissues or clots that are expelled because the fetus may be inside some of those tissues. If her pregnancy is greater than 12 weeks, we will have to assess the fetal heart tones and see if they are there. Sometimes with a Doppler, and we say greater than 12 weeks for the sake of discussion, but sometimes with Doppler it's very difficult, so we may have to use an ultrasound, which if it's really, really young pregnancy, it may be a transvaginal. As about 15, 18 weeks, Doppler's going to pick it up really well. If she's bleeding, we need to get an IV in, prepare all the equipment that the healthcare provider is going to need to examine. She may need oxygen. We've got to get all of our data together. We're probably going to get an order for type and cross match, and we have to be prepared for anything. What are her coping mechanisms? She needs to be told what's going on, what we're preparing for. We need to try to allay any of her anxieties, but she does need to be prepared. She may lose her baby, and we need to assess how she's going to be able to cope with that. And what's the family response going to be? Does she have anyone with her? Again, culture comes into a lot of what's going on here. What are her expectations? Does she need clergy available? Does she have a minister or a priest that we need to call? Some of the causes of a spontaneous abortion, of course, a chromosomal abnormality. There could have been teratogenic drugs that she took that caused a problem. The fetus could have implanted in a bad location. It may not have adhered very well. Cervix is weak, some type of placental abnormality, or some type of chronic maternal disease like diabetes or some other high blood pressure, obesity that could cause her to lose the baby. An endocrine imbalance, an infection. If she's using hot tubs or jacuzzis, these put her at risk for losing the baby or from a neural tube defect because of hyperthermia. The water is too hot. Hot tub baths, same thing. So the categories, we showed you the pictures already. There's the threatened abortion, there's an imminent abortion, and the complete, where all products of conception are expelled. And in the state of Louisiana, we can no longer just get rid of these products of conception because there are some families who still want to bury these. So we have to ask if the family wants this. Naturally, under 20 weeks, there's not a whole lot there. But we still have to ask because this was passed probably about a year and a half ago. We have to offer that to the family if they want to bury the products of conception. Incomplete abortion, some of the products are retained, most often it's the placenta. The missed abortion is when the fetus dies in utero but it's not expelled. And if the fetus has been retained for beyond 6 weeks, then it can cause mother to go into DIC. So it's very important for us to find out, and for the health of the mother, uh, she will come in, the physician will do a dissection curettage to clear all of the products of conception out so that mother won't have any issues. If she is having recurrent pregnancy losses, this is oftentimes called habitual abortion, and the criteria for that is an abortion in 3 or more consecutive pregnancies where she just cannot hold the babies. Last mom I took care of, she had gotten pregnant with twins. She could not carry a pregnancy to term, and she finally stopped trying after she lost her set of twins. Septic abortion, where these are prolonged, unrecognized rupture of membranes. It could be a pregnancy that got past an IUD in utero, or there's attempts by unqualified individuals to terminate a pregnancy, and this is what would be termed as a septic abortion. Mother ends up getting very septic, very sick, and sometimes can lose her life to these things. That's why once she gets pregnant, if she has are wanting to get pregnant, we want to get these IUDs out because it can cause a septicemia. So, our assessment as a nurse, she's going to need a speculum exam. This is why we need to get all of our equipment out. More oftentimes than not, the healthcare provider is going to want to do an ultrasound. We're going to do a HCG to see if we can confirm that she is pregnant, but we can't confirm that the embryo or the fetus is live. And we may need to do more than one HCG level to confirm the diagnosis. And naturally, an H&H is going to need to be done to ensure that she's not having too much blood loss. So for vaginal bleeding, she has not lost the baby yet. Bed rest, no sex, and much emotional support. We don't know how long she's going to have to be in bed if she's threatening to lose the baby. If bleeding persists and abortion is imminent or incomplete, she's going to be in the hospital. She's going to need an IV, probably blood transfusions, a dilatation and curettage, or a suction to get rid of the products of conception. And more than likely, we're going to give her some Rogam because of the possibility of any kind of maternal fetal sensitization for future pregnancies. I'm going to pause you right here. Okay, sorry about that. We would give Rogam because there is potential for mixing of maternal and fetal blood, and we wouldn't be 100% of what blood type the baby is. Definitely, if mom's negative, we're going to go ahead and give her Rogam. So, treatment for missed abortion, the products of conception will hopefully eventually expel simultaneously. But if they're not expelled within 4 to 6 weeks after we have confirmed there's been fetal death, she will have to come into the hospital. A dilatation and curettage, which is we call it a D&C, or suction evacuation if she's in the first trimester, or we will induce labor or D&C and evacuation if she's in the second trimester. For an ectopic pregnancy, the fertilized ovum is in a site other than the endometrial lining. We often say it may be in the fallopian tubes or somewhere thereabouts. The most common is in the ampulla of the fallopian tube, and this is about 6% of all maternal deaths in the United States, and you wouldn't understand that that would happen, but sometimes if the fetus implants in the tube ruptures, mother starts bleeding and hemorrhaging, and this could be how we might lose mom. Here's a picture of the anatomy of the fallopian tubes, and you can see where the ampullar area is, where the fetus may implant. Sometimes it can implant in the abdomen, but most of the time it's in the fallopian tube. And we call it a tubal pregnancy. Initially, the normal signs of pregnancy occur, but then there is an abnormal progression. The embryo outgrows the area, the tube can rupture, and she bleeds into the abdominal cavity. Sharp pain on one side, and it's very sharp. She'll become rather dizzy. She may have referred right shoulder pain and then lower abdominal pain. Very tender, very rigid. H&H is going to drop, and her leukocytes will increase. So we want a menstrual history. She will have to undergo a pelvic exam, lab testing, of course. More than likely, a transvaginal ultrasound is the initial test of choice so that we can see where the pregnancy is or if there's an adnexal mass elsewhere. Serial HCG measurements, and there may be laparoscopic intervention if necessary. Methotrexate is going to be our drug of choice. And surgically, a laparoscopic salpingostomy That's where they will go into the tube area and remove the pregnancy, or a salpingectomy, they may have to remove it. With both medical and surgical therapies, she is going to get RhoGAM to an Rh negative, non sensitized, because we can't be 100% that she hasn't been. So, for GTD, gestational trophoblastic disease, this is a pathological proliferation of the trophoblastic cells. It makes her look like she's pregnant. As I've told you earlier in the semester, HCG is positive as if she's pregnant, but it's going to be extremely high. Um, we really don't know why this happens. The type is a hydatid-form mole that we talked about earlier, an invasive mole, or a choriocarcinoma. This creates placenta characterized by a hydropic or fluid-filled grape-like clusters. Um, its consequences are a loss of pregnancy and a remote possibility of developing a choriocarcinoma, which is a type of cancer. So, for the complete mole, the ovum contains no maternal genetic material. It's just an empty egg, and it can be fertilized by a normal sperm. And the choriocarcinoma is more commonly associated with what we term as a complete mole, an empty egg, but it is a form of cancer. So here's what it looks like, these grape-like clusters, and they'll start bleeding, and it's a brownish color, but sometimes it is bright red. And some of these vessels are being passed, and that's what is diagnostic for a molar pregnancy. A partial mole is like a triploid karyotype. It's got 69 chromosomes in it. Now, I'm not asking you to memorize all of this. A normal ovum has 23, fertilized by two sperm or by a sperm that's failed to undergo the first division, and it contains 46. And an invasive mole is similar to a complete, but it involves the myometrium as well. But the treatment is going to be the same. So, like I said, prune juice like brownish bleeding, and it might be bright red. The uterus will enlarge, but it's going to be greater than what the gestational age should be. And she's going to pass these grape like clusters, and the HCG level is going to be very high. She may have hyperemesis gravidarum, anemia, low alpha fetoprotein, and she'll start having preeclamptic signs and symptoms before she's 24 weeks gestation. There will be no fetal heart tones whenever she has this. So, how do we diagnose? Ultrasound again is the primary. She's going to have a suction evacuation of the mole, probably your uterine curettage. She's going to get our RhoGAM if she's Rh negative, and sometimes to reduce the risk of a carcinoma, she may have to have a hysterectomy. So, malignant gestational trophoblastic disease, early detection, of course, is key. We'll do a baseline chest x-ray, a pelvic exam, and serial HCG measurements. We need to be aware of the signs and symptoms at each visit. If it's a molar pregnancy, we need to make sure they understand what the condition is and what the implications are, and provide emotional support, because more than likely she's going to have to undergo chemo. The evacuation does require hospitalization. We have to assess for signs and symptoms of hemorrhage, abdominal pain, and her emotional state again, and her coping ability. If she does require hospitalization, we've got to make sure we have blood available, because she more than likely will require a transfusion. We're going to have to give her oxytocin because just like going through labor and delivery, we've got to get the uterus to contract and clamp back down, and RhoGAM if necessary. Okay, so medical therapy for a woman who develops hyperemesis. Hyperemesis is not your normal nausea and vomiting. If she develops hyperemesis, she runs a risk of dehydration, hypovolemia, hypotensive, and tachycardia. Everything that you learned about going into hypovolemic shock can happen if she has hyperemesis. Her hematocrit will go up as well as her BUN, and if you don't understand how that can happen, go and study about dehydration, decrease urinary output, metabolic acidosis, and potentially renal impairment. She can develop a cardiac dysfunction, muscle wasting, protein and vitamin deficiencies, and she can lose her baby if it is too extensive. And we can have irreversible maternal metabolic changes, or mother can die as well if we can't reverse all the problems that hyperemesis can cause. So, our treatment goal is to control the vomiting, correct the dehydration, restore her electrolyte balance, and make sure we get her back on a nutritional regimen that she can tolerate. Small, frequent meals are usually what we will prefer her to have, because if she has hyperemesis, sometimes it can happen over and over again. So when standard approaches fail, we may have to keep her on outpatient IV fluid administration. If that doesn't work, we'll have to put her in the hospital, place her in PO, and put her on IV fluids with potassium chloride. She may be placed on phenothiazines, antihistamines, metoclopramide, and pyridoxine, which is vitamin B6. If you don't know what any of those are for, make sure you look them up. And sometimes, if we cannot get this reversed and get her electrolytes back in balance, she may be placed on TPN. If she's on home-based care, we can put her on TPN in collaboration with healthcare providers and registered dietitians, because a lot of lab work to make sure everything is in balance. Home care allows us to observe her family interactions and evaluate her environment, make sure she's got a good level of support, any kind of stresses that may be causing her to stay with hyperemesis, and we need to make sure she's got some good understanding of nutrition and self-care measures. If she has hyperemesis, she needs a relaxed, quiet environment. Anything that causes her to throw up or cause her to feel nauseated, we need to try to eliminate food odors or any offensive smells. Make sure what she's eating or drinking is attractive, makes her want to have it. She needs to have good oral hygiene. The quickest way to develop dental caries is to have this frequent vomiting and not having good oral hygiene. Monitor her weight and recommend psychotherapy if necessary. Okay, I'm going to pause here and I will be back. It's either preeclampsia or eclampsia. You need to know what the difference between the two are. Chronic hypertension, this is when she already has hypertension even before she gets pregnant. Chronic hypertension, but then she develops a superimposed preeclampsia, and hypertension of pregnancy or gestational hypertension. So, preeclampsia. She's having hypertension and vasospasms because of the gradual loss of resistance to angiotensin 2. If you don't understand all that, go back and review your patho. and a decrease in prostacyclin and nitric acid. That's the pathophysiology of exactly what's going on. She's having decreased renal perfusion, decreased glomerular filtration rate, and you should know what's happening whenever your renal system is not getting perfused. There's decreased output, retention of sodium because glomerular filtration rate is decreased. So then she ends up with increased serum levels of creatinine. Her BUN is then increased, and uric acid. So her kidneys are not working appropriately. Blood pressure's going up. She'll show signs of hyperreflexia, decreased placental perfusion, increased viscosity of blood, and she may end up developing, if preeclampsia does not get reversed and get treated, she may end up developing HELP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelet count. The main difference between preeclampsia and eclampsia: whenever she continues to have high blood pressure, she starts having visual disturbances. She may end up having seizures. Mild preeclampsia has very few symptoms. Her blood pressure is usually elevated to at least 140 over 90 or higher. She is spilling protein in the urine, usually less than 1 gram over 24 hours, or if you're using a dipstick, it's going to show 2 plus. Edema, we don't consider that as a diagnostic as we used to, but she may have generalized edema, and so we have to know why. We are going to do a urinalysis and try to determine if she's spilling protein or not. Severe preeclampsia, the criteria: it may develop suddenly. Her blood pressure is usually over 160, over 110, over at least 2 occasions, at least 6 hours apart, and she's on bed rest. Proteinuria is found to be greater than 5 grams per liter in a 24-hour urine collection. Dipstick measurement, that would be 3 plus or greater on 2 random samples that are collected at least 4 hours apart. And she may have oliguria. Her urine output is less than 500 mils over a 24-hour period. So, signs and symptoms: she'll have visual or cerebral disturbances. She may have cyanosis or pulmonary edema, epigastric or right upper quadrant pain. Liver function will be impaired, so we're going to be looking at liver enzymes, albumin, aldosterone, AST, alkaline phosphatase, thrombocytopenia or evidence of hemolysis, and the baby, there may be intrauterine fetal growth restriction. She may have a severe headache, blurred vision, narrowed segments on retinal arterioles, retinal edema, dyspnea, and she'll sound wet when you're listening to her lungs. She may have pitting edema in the lower extremities, epigastric pain, nausea, vomiting, very irritable, and very tense. This is why, if you've seen any women with really extremely high blood pressure or preeclampsia, we're putting them in a quiet room, dim lights. We're trying to keep their stress down to a minimum. So, eclampsia. This is whenever we can't get preeclampsia taken care of, and is characterized by grand mal convulsions, or they may even go into a coma. It can occur before the onset of labor, during labor, or even in the postpartum period. This is why we're so careful to monitor their blood pressure after they deliver a baby. Women may have one or they may have several seizures. So with mild preeclampsia, what are we going to do? Bed rest, primarily on their left side, daily weights. Evaluate for edema. Are they having headaches? Any visual changes? Any epigastric pain? We're going to do daily dipsticks. Blood pressures 4 times a day. Maintain good nutrition, moderate to high protein, but avoid the sodium. And we're going to assess her lab values. Complete bed rest, weigh daily, high protein, moderate sodium, put them on anticonvulsants, fluid and electrolyte replacement, corticosteroids, as well as antihypertensives. So, eclampsia, she's having the high blood pressure greater than 160 over 90. She's having visual disturbances. She's going to get magnesium sulfate IV over 20 to 30 minutes, followed by a 2 gram per hour infusion. We're going to give her antihypertensives to keep her diastolic between 90 and 100. She's going to be placed on a sedative if the mag sulfate does not control her seizures. We're listening for pulmonary edema, and if she has it, we may be giving her furosemide as a diuretic. We are watching her for renal failure and signs of cerebral hemorrhage. If she's having circulatory failure, she may be placed on digitalis. We'll put a Foley in because we're having to monitor her output, and we're going to assess her for signs of labor, watching for any vaginal bleeding, and a rigid abdomen. Oftentimes, she'll be in an intensive care setting, but if she's still pregnant, intensive care ends up being in our labor room. We may have to induce labor. We may have to perform a cesarean. She's going to still need pain relief, electronic fetal monitoring. She may have to deliver the baby in a SIMS or semi-sitting position or a lithotomy position with a wedge because we're trying to keep her blood pressure from increasing or her developing a cerebral hemorrhage, which may be fatal. So, nursing care: blood pressure, temperature, pulse, respirations, fetal well being by checking the fetal heart rate, monitoring urinary output, protein, specific gravity, daily weight for pulmonary edema. We are monitoring for deep tendon reflexes. Read about magnesium sulfate and why we need to measure deep tendon reflexes. Monitor for placental separation. Is she having a headache? Is she seeing spots? Is she having epigastric pain? We'll do lab tests, of course, assessing the level of consciousness. What is her emotional response, and what is she understanding about what's going on? Fluid volume deficient because of the fluid shift. It's shifting from intravascular into the extravascular space because of vasospasm. And she is at high risk for injury because of seizure activity that could happen. So, what are their concerns? Of course, they're fearful of losing the baby and worrying about relationships, and they're concerned about their finances. They're not wanting to be on bed rest. If she has other children, they're concerned about caring for the others. Give them as much information as we can, keep the environment as de-stressed as possible, and start bringing in support groups if we need to. Quiet, low stimulus, private room, limit visitors, left lateral recumbent position, limit the phone calls, dim lights, keep the noises down. And we've got to monitor the therapeutic effectiveness of the medications. What are the side effects of mag sulfate, and what are some of the things that we should be watching for? And we've got to provide for her safety during seizures. Remember what your seizure precautions are. So, we want the woman to be able to explain what preeclampsia is and what she's watching for. What happens if she ends up developing eclampsia and the treatment regimen? We don't want her to experience eclamptic seizures. That's why it's very important that we monitor closely. And early detection of evidence of increase in severity or possible complications is very important, because our ultimate goal is that she gives birth to a healthy newborn and she stays healthy. All right. Risks for any kind of surgical procedures that could happen during pregnancy and those complications. If we have to perform a surgery during the first trimester, there is an increased incidence of abortions. We've had some women who have developed cholecystitis, and we have tried to treat it to make sure everything is okay and not do surgery unless we absolutely have to. There is also an inability to perform some diagnostic procedures like x rays that could hinder our diagnosis of disease while she's pregnant because it is not healthy for the fetus. Surgery during the second trimester will decrease the risk of complications. We have been able to do a cholecystectomy, but after the second trimester, and do it well and have a good outcome. During surgery, we have to put a wedge underneath the mom's hip to prevent any kind of uterine compression of the major blood vessels. We may have to put an NG tube down to decrease vomiting and aspiration. We need to put in an indwelling catheter to prevent bladder distension and facilitate monitoring of output because it's vital. We have to monitor continuously the fetal heart rate before, during, and after surgery to make sure we're not having any type of fetal decompensation. Post op, all the same things that you learned last semester. We still exercise, turn, cough, and deep breathe, ventilation therapy, and early ambulation and discharge teaching, of course. Trauma to a pregnant woman and her fetus, a big complication. Blunt trauma from a motor vehicle, a fall, or violence are a priority concern. Of course, penetrating abdominal injuries. And the complications from these are maternal shock, premature labor, or spontaneous abortion. I can't remember if I've shared with you trauma from intimate partner violence. A woman came in, the whole wheelchair was full of blood. We're pretty certain her partner had hit her really hard in the abdomen and it abrupted, and she did okay. She ended up developing HELP syndrome. We did not have such a good outcome for the baby, but traumatic injuries are very detrimental to both mom and baby. High maternal mortality often is due to if there's a head trauma or hemorrhage. A uterine rupture is rare, but it is a life threatening complication of trauma, and it may precipitate a traumatic separation of the placenta or cause a premature labor. And a placental separation is a very, very high rate of fetal mortality. Penetrating trauma, oftentimes maternal prognosis is better, but if it is an abdominal wound, we oftentimes may lose the fetus. We have a high fetal injury rate with gunshots and stabbings. So, life threatening trauma, our initial focus always is on the mother. If we can't save the mother, we're not going to be able to save the fetus. So, we have to make sure we establish an airway, control the bleeding, and give fluids. She needs to stay in the left lateral position, and we may have to perform a cesarean. For non-life threatening, fetal monitoring for 4 hours should be sufficient, and if we aren't seeing any contractions or bleeding or uterine tenderness or amniotic fluid leakage, then we should be okay. If we see increased uterine irritability, we may have a risk for abruption because of abdominal trauma, so we may have to monitor for a little longer. So, CPR in late gestation. Perimortem cesarean birth is advocated if we have had an unsuccessful CPR attempt for 4 minutes. So if mom is not, if we're not able to resuscitate her after 4 minutes, it's suggested that we go ahead and perform a cesarean to have any chance of the fetus surviving. Chest compressions are less effective during the third trimester. So a cesarean improves fetal and maternal resuscitation efforts. Intimate partner violence. This is what we were wanting to get to if we could. There's a potential maternal consequence of domestic partner abuse. Oftentimes, we may lose a pregnancy. She may go into preterm labor, deliver a low birth weight infant, or there may be a fetal death due to violence. There's a higher risk of maternal complications if she's anemic, has an infection, not gaining good weight, has experienced a pelvic fracture, or a placental abruption. So, what are the needs of women who experience abuse from partners? And we are required by law to screen our women. Do you feel safe in your environment? She may be with someone in the room with her. She's not comfortable to talk, and we're going to have to help find a way so that we can make her feel comfortable. Domestic violence sometimes frequently begins or it just gets worse when she becomes pregnant. Up to 25% of women have experienced physical or sexual violence by a current or former intimate partner, and this can result in a loss of pregnancy or a preterm labor, a low birth weight, or even fetal death. Abused women have a higher rate of complications from anemia, infection, low weight gain, a pelvic fracture, abruption, homicides, high blood pressure, vaginal bleeding, UTIs, sexually transmitted infections. And we have to be alert for those non-specific signs that seem very subtle. We want to detect problems early, preferably during prenatal visits. And we have to ask about this not at just one visit and not ask about it any longer. We have to ask about it over several visits after she starts feeling more comfortable with our relationship. She may only disclose abuse after knowing who her caregivers are going to be. So, if we see any old scars on her head, chest, her arms, her abdomen, or even her genitalia, we need to assess those of potential abuse. Look for any signs of bruising. Target areas usually on the breasts, the abdomen, or even the genitalia. The psychosomatic symptoms are often a little vague because, we aren't talking to them for very long at a time, so we may not pick up on those things. Be alert for decreased eye contact, silence whenever the partner comes in the room. If she has a history of nervousness, insomnia, overdose of drugs, or alcohol problems. Our goal is to identify who's at risk, increase her decision making abilities to decrease risk of further abuse, help her to understand there are ways out. She does not have to stay in this abusive relationship, and help bring services in, but we have to empower her to feel good about herself. Create an accepting, non judgmental, safe environment for her and this unborn baby, and allow her to express her concerns. If we go in judgmental, she will shut down very quickly. She needs to be aware there are resources. We have emergency shelters, we have police, legal, and social services, and counseling available. But unfortunately, we can't force this on anyone. The client has to be the one to make that decision. So, what are the infections that the pregnant woman can come in contact with that could cause her to have a complication? Toxoplasmosis, I think we've talked about this a little bit, it's from cats. Rubella, cytomegalovirus, virus, herpes simplex virus, group beta strep, we've talked about this before, and human B19, which is parvo. Yep, pregnant women can contract parvo. I'm not asking you to memorize all of these, but have a good understanding of what the main ones are. Fetal neonatal risk of toxoplasmosis. This is when mom is pregnant and she's changing out the litter box. Retinocarditis, convulsions, coma, microcephaly, hydrocephalus, a newborn with severe infection that could die from it. Survivors are often blind, deaf, and have severe intellectual disabilities. These are all the things that can happen with a fetus. So if you have a cat, I do love my cats. I think y'all have probably heard him meowing every once in a while on these recordings. But if you're pregnant, someone else needs to change out the litter box. Prevention in the early antepartum period: avoid poorly cooked meat, no pasteurized, no unpasteurized goat's milk, because feces from any animal, or especially cats, can get into this. No contact with feces of infected cats. Someone else clean the litter box. Gardening in areas where there are cats, you need to use gloves. Wash vegetables and fruits really, really well. There are so many nice vegetable washes out there now. We should all have one. You know about all of the stuff that has come up always about our romaine lettuce here lately. So we really need to be using a vegetable wash to get those good and clean. Treatment: mom is going to have to take spiramycin in first and early second trimester. Late second and third trimester, she'll be taking pyrimethamine with sulfadiazine and folinic acid. And the baby's going to have to take the same thing if it lives. Rubella. We've talked about this from time to time. If mom has rubella, causes congenital cataracts of the neonate, sensory neural deficits, especially deafness, congenital heart defects. The baby will be intellectually challenged, cerebral palsy, and the best way to prevent: mom gets a rubella shot prior to pregnancy and try to address the pockets of unvaccinated people. CMV. If mom contracts CMV, the baby will be intellectually disabled, hearing loss, a learning disability. The baby could die. Microcephalic or hydrocephalic, it may have cerebral palsy or it may not have any damage. Baby may also be more than likely small for gestational age. Herpes simplex. This is the sexually transmitted herpes, not the herpes zoster fever blister. If mom has it and it's active, it can cause spontaneous abortion. The baby can be low birth weight. It can cause preterm labor. It can be transmitted to the fetus by the virus ascending through ruptured membranes or an infected birth canal. This happened to a baby I took care of. It kept being sick, kept being sick. Turned out it had contracted herpes. The baby eventually died. Prevention is to prevent neonatal infection. If mom has active herpes lesions, we must perform a cesarean section, and we treat newborns with cyclovir. Group beta strep, we talk about this a lot. If mom is a carrier, the baby contracts it, and we haven't provided prophylactic antibiotics. Early onset of group beta strep is pneumonia, apnea, and shock. Late, the baby can develop meningitis and pneumonia. So we screen at 35 to 37 weeks. Intrapartum, if we screen positive, we give antibiotics. If she has a urinary tract infection, we give antibiotics. If she previously gave birth to a newborn that was positive positive GBS. We give antibiotics, and we give the newborn antibiotics after it's born. Okay, hemolytic disease of the newborn secondary to Rh incompatibility. This is when we have a mama negative, baby positive. Exposure to Rh negative individual to Rh positive blood. This triggers an antigen antibody response. And so the anti-Rh agglutinin is formed and the individual is sensitized. So subsequent exposure to Rh positive blood will cause agglutination and hemolysis of the red blood cells. So you can understand why this is very dangerous. If there's a sensitization of mama's Rh negative blood, then if she gets pregnant again, it causes hemolysis of red blood cells, so she'll lose that pregnancy. So this is Rh alloimmunization sequence. A Rh positive father with a Rh negative mother. So Rh alloimmunization sequence in pregnancy with a Rh positive fetus. Some Rh positive blood does enter the mother's bloodstream. And so this is why we have to give her RhoGAM to prevent the sensitization. As the placenta separates, the mother is further exposed to Rh positive blood. So the anti-Rh positive antibodies, those triangles, those are formed, and this is what will cause her to have problems with the time she becomes pregnant. So the alloimmunization sequence in subsequent pregnancy with an Rh positive fetus, those red blood cells are attacked by the maternal antibodies, and that causes hemolysis of the red blood cells of the fetus. So the cause, the woman carries, an Rh negative mom can carry a Rh positive fetus, either to term or determination by a spontaneous or induced abortion, or by an Rh positive blood transfusion to a Rh negative non-pregnant woman, or fetal blood cells invade maternal circulation, and this stimulates the production of Rh antibodies. Transfer of RBCs from the fetus to the mama will occur during birth. The first offspring is not affected. These are the subsequent pregnancies that would be affected because the antibodies cross the placenta, they enter the fetal circulation. So these destruction of fetal RBCs will cause a fetal anemia, and it will damage, the damage is proportional to how much sensitization the mother has experienced. We don't want to take the chance. We give RhoGAM to the mom, and failure to administer RhoGAM may result in erythroblastosis fetalis, which means hemolysis is caused by maternal IgG antibodies in the fetus, which causes fetal anemia. So we usually give this to mom at about 28 weeks. And we give it to her again after delivery. And I believe I've told y'all before, we're seeing now, depending how much mixing of the blood has occurred whenever we do a fetal screen, depends on how much RhoGAM she'll actually get. Failure to administer RhoGAM may result in, like I told you, erythroblastosis fetalis. There will be what's called hydrops fetalis, which is marked fetal edema. Sorry, my phone is ringing. I'm going to pause just a second. Sorry about that. Congestive heart failure can happen. The baby can have marked jaundice, which is another name is called icterus gravis, or neurological damage. This is whenever the bilirubin goes extremely high, critically high, and this is called kernicterus, and that causes neurological damage. So, prenatal screening, we want a history of past pregnancies, previous sensitization, any abortions, blood transfusions, or children who have developed jaundice or anemia as newborns. And we need to know what the mama's blood type and Rh factor is. We need to know any other complications she may have, like diabetes, infections, or hypertension, and we're going to do an indirect Coombs test on the baby, which is an antibody screen. The indirect Coombs determines whether an Rh negative woman is sensitized to the Rh antigen. If she's not sensitized, the second antibody screening test is performed at 28 weeks gestation. If sensitized, the mother's antibody titer is obtained. And I need to redirect myself. The indirect Coombs is going to be done on the mom. We'll do a direct Coombs on the baby if we need to. Women with elevated antibody titer, we need to consider them sensitized, and we have to manage them very, very closely. This is why those histories are so very important. So, indications for RhoGAM. If she has a negative antibody screen at 28 weeks, situations in which the woman, Rh negative woman, and not sensitized, and the father is Rh positive or where it is unknown, or if she's had maternal trauma, because if she's had maternal trauma, we can't be sure about mixing of the fetal blood with maternal blood. So, two primary interventions help the fetus whose blood cells are being destroyed by maternal antibodies. We either have to deliver the baby early, or we have to have a maternal fetal specialist to come and perform an intrauterine transfusion. But ideally, we should not delay the birth until, we don't want to have long immaturity, so we really need to delay as long as we can until 36 to 37 weeks if possible. Postpartum, we're going to give RhoGAM 72 hours after childbirth to Rh negative moms with no antibody titer, like the indirect Coombs test is negative, not sensitized, and who have given birth to an Rh positive fetus who has a direct Coombs test negative, which means there's no sensitization. We do not give RhoGAM to the newborn or to the dad. And what we're seeing now is we're seeing more administration of RhoGAM, sometimes up to 3 or 4 injections or IV push. So we need to assess what the maternal blood type is and the Rh factor. What is mother's knowledge about this? If they've gotten RhoGAM before, they're going to tell you. Outcomes of any previous pregnancies. Of course, we're going to assess our lab data very closely. Ongoing assessment during procedures that we do, and if she's going to need RhoGAM. Antepartum, we want to give them education about what's happening if you're Rh negative and the Rh positive dad and a mama is negative and the baby is positive. Why is it important to receive RhoGAM after you have an abortion or an ectopic pregnancy? Why do we give RhoGAM at 28 weeks if she is not sensitized? And she's going to need a lot of emotional support. During labor, for an Rh negative woman who has not been sensitized, we want to assess her blood for antibodies and ensure that we have cross-matched her blood for Rh immune globulin. Postpartum, the nurse is the one responsible for administering IM RhoGAM if the newborn is Rh positive, and now we can also administer RhoGAM by IV push. Okay, so if we've got an ABO incompatibility, what happens? the mother is type O and you've got a baby who is type A or B, and you have maternal antibodies present in the serum. This can cause a hemolysis of fetal red blood cells, and a severe anemia does not generally occur.